Hello everyone, hope you're all doing good. In this video, we are going to see about the prenatal diagnostic tests. So basically, these tests are done to confirm the chromosomal or genetic abnormality we suspected with the screening methods. Okay, we'll see some indications. Indications include maternal age more than 35 years. When there is a past history of fetal chromosomal abnormality, or when there is a family history of genetic disorder, when either of the couple are suffering from translocation, namely reciprocal balanced translocation or the Robertsonian translocation, and in the mother when there is any chronic disease conditions like hypothyroidism, diabetes, hypertension, or even autoimmune diseases. Okay, and also if there was an abnormal serum screening, okay, or there was an abnormal ultrasound markers, okay, the soft markers we have discussed in the screening session, and also if there is any abnormal exposure to drugs, smoking, alcohol, and if there is use of any teratogenic drugs like anticonvulsants and any teratogenic infections like the viral infections like cytomegalovirus and rubella. Also, if she has conceived through the artificial reproductive techniques and there was an exposure to X-rays or lead. Okay, so we are going to discuss about some of the few important diagnostic test methods. So, prenatal diagnostic test that we are going to discuss here is number 1, amniocentesis. Number 2, chorionic villus sampling. Number 3, the fetal blood sampling or percutaneous umbilical blood sampling. Okay, so these are the most important things we are going to discuss. First, we will discuss about amniocentesis. In amniocentesis, the amniotic fluid is withdrawn transabdominally, okay, under direct USG guidance, okay, and it is usually done between the gestational weeks 15 to 20 weeks. Okay, and if you see, what we'll be doing is a 20 or 22 gauge needle we'll be using mostly, and it is inserted by aseptic technique into a amniotic fluid pocket. Okay, and usually a closest amniotic fluid pocket is selected. Okay, and then we'll be inserting the needle perpendicular to the skin. Okay, and then we should be passing the needle and gentle puncturing of the chorioamnion is done. This is puncturing the skin of the fetus. Okay. After this, you have to check for the color of the fluid aspirated. Generally, amniotic fluid will be pale, or you can even say a colorless or a clear fluid. Okay. Sometimes even a blood tinged fluid can be aspirated. Okay. In this case, you have to know that there would have been a transplacental passage of needle. Okay. Generally, it happens 60% of the cases when there is a anterior placenta. Okay. What you have to do is, you have to continue the aspiration. Okay. As you aspirate, the blood will become clear. Okay. And then in this case, you can discard the initial 1 to 2 ml of fluid aspirated, as it may contain maternal blood cells. Okay. We have to aspirate up to 20 to 30 ml of fluid. Okay. And this has to be sent for CMA or karyotyping. And remember, you have to document. Okay. Important is document the fetal cardiac activity after the procedure. Okay. And suppose if the mother is RH negative, that is if it was a case of RH negative pregnancy, you have to give anti-do immunoglobulin also. Okay, this also to be given. Understood? And next one is, so this is how the procedure is done. Okay, basically you are going to insert a needle via the abdominal wall, and it has to pass through the uterine wall, the membranes, and it has to reach the easily accessible amniotic fluid pocket, and you are going to aspirate the fluid. Okay, so we'll see what are the complications you can expect with this. Okay, there can be a chance of pregnancy loss around 0.1 to 0.3%. Okay, and it can be reduced by an experienced provider of the procedure, and there can be chance of amniotic fluid leakage, which can occur in 1 to 2% of the cases, and then there can be transient vaginal spotting also. Okay. So this is also encountered in 1 to 2% of the cases. And then we can go for early amniocentesis. Okay. So early amniocentesis means performing the amniocentesis around 11 to 14 weeks of gestational age itself. Okay. But this has a complication of going to the club foot. Okay. So usually early amniocentesis is not done. Okay. But with this procedure, needle injuries to the fetus are rare. Okay. Now we'll see chorionic villus sampling. Okay. In chorionic villus sampling, we are going to take biopsy of the chorionic villi as usual under aseptic conditions and under direct ultrasonogram guidance. Okay. And when it is usually done means it is done between 11 to 13 weeks of gestational age. Okay. Now, what is the advantage of this chorionic villus sampling means? See, this is done at a earlier gestational age than amniocentesis. So, it will give a better time interval for decision making, counseling and pregnancy termination can also be done at an earlier stage itself. Understood? Yes. And remember, you can do this procedure through two routes, either by transabdominal route or transcervical route. In transabdominal route, you can pass a 80 to 20 gauge spinal needle through the abdomen, and in transcervical route, you can pass a flexible polyethylene catheter. Okay. Now, what you are going to do is, you are going to aspirate the contents of early placenta, which is going to contain chorion frondosum. Okay. And this is going to be aspirated into a needle that is containing culture media. Okay. And then it will be sent for karyotyping or CMA, chromosomal microarray. Okay. And if you see this picture, you will be able to identify it. Okay. So, this is a transabdominal procedure. Needle is inserted through the abdomen to take out the placental tissue. Okay. You are able to see this is the chorionic villi. This is the chorionic villi over here in the placenta, and this is the uterus, that is the womb, and this is the cervix. Okay. We are doing it under ultrasound guidance. Okay. And if you see this method, we are going to pass a catheter in the transcervical route, and this is the uterine wall, placenta, okay, and the chorionic villi. So, this is going to be get aspirated. Okay. And also remember, you have to give RH. If she is a RH negative pregnancy, then don't forget to give anti-D. And another point is, fetal heart rate should be documented after the procedure. Okay. Now, what are the contraindications? Okay, contraindications of chorionic villus sampling. Okay, Relative contraindications include vaginal spotting, if there is any active genital tract infections, or when there is extremes of uterine retro or anteflexion. Okay. Now we'll see some of the complications also. Complications of chorionic villus sampling include limb reduction defects, okay, then oromandibular hypogenesis, okay, and this usually occur when it is performed even earlier, okay, less than 7 weeks, and the procedure loss rate is again 0.1 to 0.3 percentage, okay, and there can be vaginal spotting and amniotic fluid leakage, okay. So this can occur in 0.5% of the cases, less than amniocentesis, and chromosomal mosaicism can be seen in some cases, okay, in some cases. So what you have to do is, you have to offer amniocentesis, okay. So mostly this mosaicism will be from the placenta, so there will be a placental mosaicism that can be leading to fetal growth restriction, okay. Next we will discuss about fetal blood sampling or Cordocentesis or PUPS, that is Percutaneous Umbilical Blood Sampling, okay. So what are the indications of doing this? Indications include fetal anemia. So if fetal anemia is found, you can do fetal transfusion, okay. Then for fetal karyotype determination, suppose you did amniocentesis as well as chorionic villus sampling, and in that if you are finding a placental mosaicism or any chromosomal mosaicism, then you can confirm this by doing this procedure, okay. And then it is usually performed near the umbilical cord insertion site in the placenta, okay. Or alternatively, you can go for puncturing up of the cord also, okay, that is umbilical cord. So in this we will be taking a 22 gauge needle and about 2 to 5 ml of blood is aspirated, okay, and the syringe will be a heparinized syringe, okay. So doing these procedures, we should avoid arterial punctures, because if we do arterial punctures, there is chance of vasospasm or it may lead to bradycardia in the fetus, okay. Then as usual, fetal cardiac activity is to be documented. Okay. Other complications you can expect with this procedure include there can be feto-maternal hemorrhage. So remember to give anti-D if it is a RH negative pregnancy, or there can be fetal bradycardia as we have already discussed. Okay. Then now we will discuss about karyotyping. So in karyotyping we are going to count the number of chromosomes as well as we are going to look for any structural changes in the chromosomes. Okay. And remember, this is a highly accurate diagnostic method and it will take some 7 to 14 days to obtain the results. Okay. Basically, it is done by metaphase analysis of the cultured amniocytes or chorionic villi cells. Okay. So this is how you will be getting a karyotype report. See, this is a report of trisomy 21 or Down syndrome. If you see in the 21st chromosome, there is a trisomy. Okay. The same way, can you tell me what it is? One X chromosome is missing. That means it is 45X0. So this is a karyotyping of Turner syndrome. Okay. So this is how you will get a karyotyping report. And then we'll see about CMA, that is chromosome micro array. Okay. This is usually performed on uncultured or cultured cells. If it is performed on uncultured cells, you can get the reports in 3 to 7 days. If it is performed on cultured cells, it will take some 7 to 10 days to get the report. Okay. And then, if you see, this is the most accurate method. Okay. It even picks up the submicroscopic changes, okay, that are too small to be detected by karyotyping. Okay. Next we will see fish. Okay. What does fish means? It is fluorescent in situ hybridization. Remember, it is carried to specific chromosomes. Okay, this procedure is carried out for specific chromosomes. We can target chromosome 18 or 13 or 21. Okay, and the results you can get it in 24 to 48 hours. Okay, if there is a doubt, this can be further confirmed by karyotyping. Okay, and one more thing I want to discuss, that is pre-implantation genetic diagnosis. Okay, So from the name itself you are able to identify. Before the implantation stage itself, we are going to take some cells and check whether there is any abnormality in the cells. Okay. So this is usually performed on either the trophoectoderm at the blastocyst stage or the blastomeres of the cleavage stage or even the polar bodies of the oocyte. Okay. Now, there are various types of pre-implantation genetic diagnosis test. Okay. So, it can be PGTA, where the pre-implantation genetic testing is done for aneuploidy. Okay. Or it can be PGT-SR, where the pre-implantation genetic testing is done for structural rearrangements. Okay. Or it can be PGT-M. Okay. So, pre-implantation genetic diagnosis testing for monogenic disorders. Okay. So, this is how the tests are performed. So, this is a polar body testing, first and second polar body biopsy, and in the day 3 we can go for cleavage stage biopsy, and this is a trophoectoderm biopsy where we will be taking the trophoectoderm from the blastocyst. And remember, in this there can be any false positive or false negative test reports. So, finally you have to confirm this again via doing amniocentesis or CVS or karyotyping in the future. Okay. Now, with this we are finishing this topic. Until we meet in the next topic, happy learning, keep going and take care.